Good morning. Today, our topic of discussion is apexification. Apexification is a treatment option for non-vital young permanent tooth. What do you mean by young permanent tooth? Young permanent tooth is a tooth that has erupted recently into the oral cavity. So, what are the peculiar features of young permanent tooth compared to a mature tooth? They have comparatively more permeable primary dentine and semi-permeable enamel, low calcium and phosphate, high cellularity, high vascularity, presence of mamelons and absence of attrition, pronounced pericymata and enamel rods. But our concern here is regarding the apex of the young permanent tooth. They have open apex and thin dentine walls. So when this young permanent tooth becomes non-vital due to caries or trauma, our treatment option will become root canal treatment. But it is quite challenging in these teeth because of the absence of an apical stop or apical barrier against which you can pack your gutta points. There are two types of open apices. One is called blunderbuss apex, where the walls of the canal are divergent and flaring, and the apex is funnel shaped and typically wider than coronal aspect of the canal. And non-blunderbuss, where the walls of the canal may be parallel to slightly convergent as the canal exits the root. Apex therefore can be broad or tapered. Since routine root canal treatment are not possible in these teeth, our treatment option is either surgical management or non-surgical management. In surgical management, we do periapical surgery with a retrograde filling, but it is not advised in children. One reason is psychological reasons where surgeries are avoided in children, and another reason is thin dentinal walls may fracture, making surgery difficult, and also episectomy further reduces the root length, resulting in a very unfavorable crown root ratio. Here comes the importance of non-surgical management, that is apexification. So what are the indications of apexification? Immature teeth with pulp necrosis, no vertical or horizontal root fractures, no radiographic evidence of replacement resorption. Root length must be approximately half or more established, and teeth must be ultimately restorable. An apexification can be done as multiple visit procedure or single visit procedure. Multiple visit procedure, the medicament of choice is calcium hydroxide, whereas in single visit, MTA, biodentine, etc. are used. The traditional apexification procedure is using calcium hydroxide. It is mixed with saline or CMCP, that is camphorated monochlorophenol. Frank has described the traditional apexification procedure. It is, as I told you, a multiple visit procedure. And you all know that the tooth is non-vital. So initially, an access is gained into the root canal, similar to that of the routine RCT. But here the access cavity has to be little more enlarged for the introduction of instruments and introduction and removal of the medicaments used. So following gaining access into the root canal, the coronal as well as the radicular infected pulp is removed. And while doing the biomechanical preparation, care must be taken to consider the thin dentinal walls and the open apex. If there is swelling or abscess, drainage can be established for 24 hours and antibiotics can be prescribed. Otherwise, following the routine irrigation protocol, an intracanal medicament is sealed and the patient is recalled after 7 to 10 days. And in the second visit, upon re-entering the canal, again thorough irrigation and cleaning is done and the entire canal is filled with calcium hydroxide preparation, and care must be taken to ensure that the canal is filled up to the apex. And then a permanent type of restorative material is used to close the access cavity in order to prevent or avoid coronal leakage. And patient is recalled at regular intervals, 2 to 3 month intervals, and until a calcific barrier is formed. And after formation of the calcific barrier, routine RCT and gutta-percha point obturation is done. Wayne has described 4 types of root and closure following these type of conventional apexification procedure. One is continued closure of the canal and apex to a normal configuration. And second is the apex closes but canal remains with a blunderbuss configuration. And third, no radiographic change, but a thin osteoid-like barrier provides a definite stop at or near the apex. And last one, radiographic evidence of a barrier short of the apex. But this routine apexification procedure has various shortcomings. Calcium hydroxide may damage the Hertwig's epithelial root sheath and thereby destroy its ability to induce the nearby undifferentiated cells to become odontoblasts. Increased risk of tooth fracture using calcium hydroxide and the long time span of the entire treatment and multiple visits with heavy demands on patients and caretakers and inevitable clinical cost. Hence, instead of this routine apexification procedure, the one visit apexification is preferred. Here, the rationale is to establish an apical stop that would enable the root canal to be filled immediately, thus avoiding multiple visits. Here, no attempt at root and closure, rather an artificial stop was created, and the even though many materials are proposed for this, the frequently used materials with high success rates are MTA and Biodentin. So here also, after the root canal opening and cleaning and drying, the MTA apical plug is placed at the apical area, followed by which Gata-Pacha obturation is done. MTA apexification has the advantages like it sets in wet environment and satisfactory compaction of filling material can be achieved as MTA forms hard and non-resorbable apical barrier. It neither gets resorbed nor weakens the root canal dendine, and it is most biocompatible and bacteriostatic material with good sealing property which stimulates cell growth, adhesion and proliferation, and this represents a primary monoblock. But as you know, there is no thickening of the dentinal walls as in case of a vital therapy, and also the tooth is again prone to fracture. Hence, a newer treatment modality has been put forward that is called as pulp revascularization. It is based on the concept that vital stem cells located in the apical papilla can survive pulpal necrosis even in the presence of a periradicular infection. Osby introduced this concept, and histological evidence of successful revascularization of immature permanent teeth after reimplantation has been reported by many authors. Here, the necrotic uninfected pulp acts as a scaffold for the ingrowth of a new tissue from the periapical area. Here, absence of bacteria is a primary concern for the success of pulp revascularization. And the apical opening more than 1 mm mesiodistally is also associated with successful revascularization, whereas no revascularization occurs in teeth with a smaller apical opening. So traumatized, immature, permanent teeth with an open apex diameter of greater than 1 millimeter are best candidates for revascularization. And also it is limited to age group of 8 to 16 years because the healing ability will be more in that age group. There are 3 steps mainly. One is disinfection of the canal, then placement of a matrix in the canal for tissue ingrowth, and bacterial tight seal of the access opening. The procedure of revascularization is as follows. An access cavity is prepared and the necrotic nature of the pulp is confirmed, and thorough irrigation protocol with sodium hypochlorite and chlorhexidine and hydrogen peroxide can be done, and various intracanal medicaments like triple antibiotic paste are used because infection of the root canal system is considered to be polymicrobial in nature. And these antibiotic combination consists of metronidazole, ciprofloxacin, and minocycline. And various concentrations have been tried, and after obtaining a sepsis in the canal, epinephrine-free anesthetic is administered, and an endodontic explorer is introduced into the canal until vital tissue is felt in the canal space. And an explorer can be used to irritate the tissue gently to create some bleeding into the canal, and the bleeding is stopped at a level 3 to 4 millimeter below the level of CEJ and left for 15 minutes so that the blood would clot at that level. Then MTA is carefully placed over the blood clot, followed by a wet cotton pellet, and the cavity is sealed. And in the later on, the patient is followed up at regular intervals, and successful revascularization has been obtained. Thank you.